Good. Well, good evening, and thank you all for coming, and thank you all for all the support that you offer, really, for our clinical and our research work. Just to introduce myself, I'm James Murray, and like Andrew, I have a joint appointment which is partially with the university and partially with the hospital. So I do both clinical and research work. I'm slightly different from most orthopaedic surgeons in that I originally trained as an engineer, and while I was an engineering student, I came across joint replacements which were then just being developed, and I thought it would be fun to get involved with development of joint replacement. And I thought the best way to do that would be to become a surgeon, and that was great. And I hadn't at that stage realised that it took 15 years to train to be a surgeon. So by the time I trained to be a surgeon, all the main the sort of early inventions of the joint replacement have been achieved, and now we've got out the far end, we're improving them. But actually, we're fortunate that we have a technology that works really well. And actually, joint replacement, you probably are aware, is one of the three most successful interventions in the whole of medicine and surgery. The only two other ones that are really as effective are cataract surgery and coronary bypass surgery. As you know, we have patients in severe pain, severely disabled. We do a joint replacement, we get rid of their pain, and if they're elderly, they don't really need anything else. It's a wonderful procedure. But unfortunately, in the younger patients, it isn't quite so good. And there are really two reasons why they don't work quite so well in the young. First reason is that they tend to fail or to wear out, and that's partly because they need to last much longer. If you operate on a 40-year-old patient, you're going to need an implant that lasts 40 years, and partially because the patients are much more active. So we do have problems with both hip and knee replacements that they tend to wear out. So we need to develop hip and knee replacements that last a bit longer. And also on the hip side, hip replacements work fantastically well. They just seem to restore patient function. But on the knee side, they don't work so well. And certainly 20 or 30% of patients, particularly if they're young, have rather disappointing results because of poor function and inadequate pain relief. So what I thought I would do today is, I haven't prepared much of a talk, I've just bought some pieces to talk about. And I could talk about these implants for hours, but I will try and just give you a brief summary of the sort of improvements that have happened over the last maybe 10, 15 years. And then if you have any questions, we can address those at the end. Now, we'll start off with a hip replacement. I'm afraid these implants are quite small, so Paul has brought a camera so I can perhaps demonstrate them to you. But I suspect many of you don't really even know what a hip looks like, so I've brought one today. I'm not sure quite, I know how it goes together. But we have a pelvis, we have a leg, femur, yeah, the technical term, and basically the hip's a very simple joint. It's a ball in a socket, and the femur is hollow, a bit like a bamboo, so the traditional hip replacement was to chop off the head of the femur. And actually, can I just have, yeah. This actually is a hip replacement stem from the 1960s that actually worked incredibly well, and that goes down inside the femur and it's cemented in. And the traditional socket was a bit of polyethylene, plastic bag, actually, material that you cement in. And that's the traditional hip replacement. It's interesting just to observe that Charnley, who developed the hip replacement, he originally used Teflon, thinking that was the slipperiest surface known to man, but that failed catastrophically, and so he virtually gave up doing hip replacement. But actually a salesman from ICI happened to come in and say, I've got a nice new material to use as handles for your instruments. Try it. And actually he tried it for his hip replacement, and it worked wonderfully well. Well, it works wonderfully well, really, in elderly patients. In the young patients, we've had problems because the polyethylene wears out. The other problem in the young patients is that the implants work loose. So, what have we done about that? Well, actually, this is the, no, Yeah. No, I don't know if you can see that. Is it better to see it by the cameras or holding it up?
Camera.
Camera at the back, I'll hold it up. So anyway, this is the 30-year-old one. And actually, this is the one that we use today. And actually, this is also this is about 30 years old as well. This was developed in Exeter. It's called the Exeter. And it's very clever. This is cemented, but it's polished. And if it works loose, it just sinks a bit more into the cement and it locks itself solid. So actually, this is what we use in just about everybody today. A wonderful implant. But many people don't think. Many people don't like the cemented implants, and that's perhaps because they're rather difficult to put in. So most of the world uses implants like this, which are cementless. And you just hammer them into the bone, and you see they have a rough surface that the bone can grow into. And these work well, but actually we've tried them. We've tried quite a few here in Oxford, and occasionally the tip of the implant irritates the femur, the thigh bone, and you can get thigh pain. So we've rather stopped using those and still use the cement. So, yeah. So we found that cementing the socket is unreliable. So actually now, we always now use what we call a cementless socket. And this we hammer in instead of cementing in the polyethylene. And it has a rough surface, and it's actually titanium. The bone likes to stick to titanium. So on top of the titanium, there's a coating of hydroxyapatite, which is a mixture of calcium and phosphorus, and actually has the same chemical constituents as bone. So it actually hoodwinks the bone cells, and they think it's bone, and the bone joins onto it. So this is useful partly because it gains good fixation, but also we can use different types of materials for bearing surfaces. So what we've started to do more recently for our young people is use a device like this, which has a ceramic ball and a ceramic liner. And actually this really doesn't wear at all. And almost all our young patients, I will talk about one subgroup, but almost all our young patients get the ceramic on ceramic. It's interesting that it's actually worked very well for us, but in the United States they have great problems with this device squeaking. There are actually videos. I've got a video on YouTube that sounds just like a rusty door. But actually, we haven't had one patient that squeaks. So I don't know why that is. And there is another problem. The ceramic is occasionally it shatters, and that's a real disaster. But actually, with modern ceramics like this, they don't seem to break. So that's ceramic on ceramic. Theoretically, it seems, particularly in young people, it seems foolish to actually remove the head of the femur, the ball. And from a theoretical point of view, it's a very nice idea just to resurface the ball. And people have tried resurfacing the hip for many years. In fact, Charnley tried 40 years ago, and all the early resurfacing replacements didn't work well because they were metal on plastic, and the plastic was very thin, and it failed.